Good afternoon, and welcome to the next in the series of policy webinars that Care for the Homeless produces. This one is entitled The Future of Healthcare for People Experiencing Homelessness. As many of you, I hope, know, Care for the Homeless is a federally qualified health center. We've got an ambulatory care network that serves homeless and unstably housed people exclusively, with 16 sites across New York City, serving all 5 boroughs. We also operate 6 residential programs, plus a variety of social services. But the third part of our mission, and I like to refer to this as the smallest but mightiest part of our mission, is our policy and advocacy efforts. And we do that for a couple of different reasons. One is that we want to participate in the public dialogue about solutions to homelessness. So much of the information that the general public gets about homelessness comes from tabloid newspapers that demonize homeless people and make homelessness look like an intractable problem. And so we feel an obligation, because we know that there are solutions to homelessness, we feel an obligation to communicate those solutions to the general public. It's also an opportunity for us to give a voice, to amplify the voices of people with lived experience of homelessness. Those are the 2 key missions of our policy and advocacy division. Our goal for today is that you walk away from this seminar with a deeper understanding of how holistic healthcare can become and is a cornerstone in the movement to end homelessness. I'd like to thank all of our attendees for joining today. I think we're going to have a very rich panel. Before we get started, I'd like to invite folks to participate in a poll that's going to pop up on your screen. This is a tool for us to understand who is participating today. So please take a moment, complete the poll. I'll give folks a minute here, and then we'll get started with the seminar. Thank you for completing the poll. It's now my great pleasure to introduce our moderator, a great friend of Care for the Homeless and a great leader in the movement to end homelessness in the United States, Jeff Olivet. Jeff is an internationally recognized leader in public health and homelessness policy. He has more than 3 decades of experience as an outreach worker, advocate, researcher, teacher, writer, and inspiring public speaker. He currently serves as a senior advisor to the Initiative on Health and Homelessness at the Harvard T.H. Chan School of Public Health. And he also consults with organizations across the United States as well as internationally. Previously, Jeff served as the nation's top homelessness official, leading the United States Interagency Council on Homelessness. We are honored to have him guiding today's discussion. I know that you all join me in warmly welcoming Jeff Olivet.
Thank you so much, George, and it's wonderful to be with you all. Thanks to everyone who took the time to be here this afternoon. And it was nice to see that poll of just all of the roles that you all play as homeless service providers, healthcare providers, advocates, activists, academics, concerned community members. It really is a wonderful cross-section of folks who care about this issue. As you all know all too well, homelessness is a life and death issue. Homelessness can often be the result of medical conditions, of medical debt, of a crisis of mental health or addiction, but it's always grounded in the loss of housing. That's the one common denominator. And one thing that we say a lot in the healthcare for the homeless movement is that housing is healthcare. We know that getting people into the safety of their own home is the best medicine for people who are experiencing homelessness. We also know that while people are living on the street, in shelters, under bridges, in encampments, in vehicles, that getting healthcare to them is one of the most important things we can do. The street medicine movement and the street psychiatry movement, of which care for the homeless as an integral part over the last few decades has been a cornerstone in addressing the urgent health needs of people experiencing homelessness. And my background is as a healthcare for the homeless outreach worker. I was a case manager and an outreach worker with Albuquerque Healthcare for the Homeless about 30 years ago. And then starting about 20 years or 25 years ago, I got to know Care for the Homeless and ended up working with Bobby Watts and with George and with many others there. And I'm just an enormous admirer of the work that Care for the Homeless does in the world. I am thrilled to welcome an incredible group of panelists for the next hour and a little bit to discuss a range of issues facing people experiencing homelessness as we think about the future of healthcare for homeless folks. And as I introduce the speakers, I'm just going to invite you all to come off camera, and then we'll get into the discussion. First, Will Woods is joining us. Will is a board member and an advocate at Care for the Homeless in New York. Will, welcome. We're also joined by Deputy Mayor Helen Arteaga. Dr. Arteaga is the New York City Deputy Mayor for Health and Human Services. Deputy Mayor, it's great to have you here today as well. Thirdly, a longtime stalwart in the healthcare for the homeless field, Dr. Barbara DiPietro is Senior Director of Policy at the National Healthcare for the Homeless Council and has been instrumental in shaping the national discourse around health and homelessness for many, many years. And finally, Dr. Margot Kuchel is joining us from the West Coast. Margot, I'm assuming you're in the Bay Area today. I don't know if that's right or not. Dr. Margot Kuchel is the director of the Benioff Homelessness and Housing Initiative at the University of California in San Francisco. And Margot is also a practicing physician at Zuckerberg San Francisco General Hospital. And the group of folks who have assembled here is just an extraordinary brain trust around this intersection of health and homelessness. And I've got a number of questions for you all, and then we're going to open it up to the audience for questions towards the end. But before we get going, I'm going to invite each of you just to say some brief opening remarks about, when you think about this intersection of health and homelessness, what do you think people need to know? What is most on your mind these days? And I think we'll begin with Will and just go in the order that I introduced folks to get us going. Will, take us away.
Thank you, Jeff, and thank you for the introduction. I think for me, especially this kind of living in the intersection of understanding some of the policy work and then kind of marrying that to my own lived experience, is this idea that while we're starting to do a really good job of equating having housing with one aspect of addressing and defeating homelessness, that addressing healthcare is the other part of that triangle, and we're lagging a little bit behind on that. Healthcare is just as important. Just starting from the stability that allows folks to progress and grow, but also just the idea that a lot of people experiencing homelessness are coming from chronically underserved and chronically undereducated communities that aren't very attached to good health care. And the quicker and the more and the faster that we start to put those things together, we can start to re-extend lives that have been negatively impacted by their exposure to homelessness.
Thank you all for joining. I think that's the end of today's webinar. I hope you enjoyed it. Well, that was just so beautifully said. Really, thank you for that grounding and the framing of health and housing and homelessness. I really appreciate you being here. Deputy Mayor, what's on your mind around this?
Um, Echoing what Will has said, shelter and healthcare are combined. When we look at the most essential needs of any human being, housing and shelter is number one. And then we need to make sure the health piece in there to make sure not only were we meeting the client where they are, but making sure that they're thriving for like their future lives. But I would add to that technology. I think we need to add technology to the work that we're doing. We need to make sure that we're able to track and get real data from the populations that we're serving to make sure that we're solving the right problem because we only have a little bit of amount of resources, right? I only have X amount of dollars to make sure I'm meeting the needs of X amount of community members. And I need technology to make sure and running the right data to make sure making sure that every dollar I have is going at max resources for the individuals that I need to help.
Thank you for raising that. I think, sometimes people hear conversations about data and start thinking it's like detached from the humanity of the people we're talking about. And it is the humanity of the people we're talking about. There are people behind every one of those numbers that you're looking at. But there's also this question that I think you're getting at of how do we even know what works unless we're really doing a good job understanding our data, the size and scope of the problem, how people may interact with multiple systems in our community, and what's most effective in helping people exit homelessness. Thank you for that. Barbara, you work both at the local level in Baltimore and at the national level around homelessness and health policy and legislation and advocacy. What are you thinking about these days?
So I would plus one to what Will and Dr. Arteaga said, but I would add too that good care needs to be supported by good public policy. And right now we're in an environment where we have a lot of policy changes that are going to have a direct impact on the care that we can provide. And so I'm very concerned about that. That's something I spend a lot of time thinking about. And I also think about how another integral piece of the healthcare for the homeless community is integrating our service with our advocacy. And so, as healthcare providers, our story is one that is accurate to on the ground operations. The people that we serve and care for are part of that story and part of that discussion. And so, I'm thinking a lot about how we can be really active in telling our story, working with policymakers to be able to forge ahead with the healthcare that we know works, supported by sound public policy. So, that's really what I'm thinking a lot about these days.
And I think we'll come back to both of those topics as we get into our conversation, both the policy landscape that we're operating in. I know we want to talk about Medicaid cuts and the future of Medicaid waivers and some of those kind of financing mechanisms for how we provide good health care for people who are homeless. And I'm intrigued by your comment about integrating service and advocacy, and I'm going to bookmark that, and we may come back and talk about it as we have time. Margot, you've been at this both as a clinician and a researcher and an advocate. What are you seeing? What are you thinking about? How do you want to lead off this conversation?
Sure. Thanks for inviting me to join this panel. Agree completely with what everyone said. And maybe what I will add is I think one of the current policy confusions that we have is the bidirectional nature between health and homelessness, that poor health can be a trigger to homelessness, both through what the public thinks about mental health and substance use crises can certainly trigger it, also in physical health crises. I see all too often, an elder who has a premature stroke because they haven't had good access to care. That stroke leads them to not be able to do their job anymore. And our safety net is so broken that then leads them to not be able to pay their rent and to become homeless. But also the bidirectional nature. There is nothing worse to your health than losing your housing. I always say, as a physician, there's no medicine as powerful as housing, because really there's so little that we can think of that damages someone's health as much as homelessness. So one is to really focus in on the bidirectional nature. And I think from that, as healthcare providers, it really then sets out what our role needs to be. Like, we need to be sure that we're not contributing to this through medical debt. We need to be seen as a place where we can recognize people at risk and help advocate, and also, frankly, get them into things like prevention programs and things like that. But I think healthcare providers need to work hand in hand with homeless service providers, with housing providers, to match people's needs to the care that they receive. We know that we can treat people with addiction very successfully. We can treat people with mental health problems very successfully. We can manage strokes and high blood pressure and all of those things, but we need to be there at the table, walking hand in hand with homeless service providers and housing providers.
Thank you all for just identifying a number of issues that I think can frame up our conversation for the next hour or so. Margot, I'm going to start with you. I think you were already beginning to move into the specific kind of clinical needs, healthcare needs of people experiencing homelessness. Your statewide study in California explored this in great detail. That was one of the most ambitious studies we've seen on homelessness in 30 years in this country. What did you learn from that study, and what do you see as the most pressing health needs of people experiencing homelessness?
I mean, I think one phenomenon that we've been seeing around homelessness around adults. Obviously, 1 in 4 people who experience homelessness are children, and so, but just focusing right now on adults, one of the perhaps changes in the last 30 years is the aging of the population. That this has increasingly, both in our permanent supportive housing, but also amongst those experiencing homelessness, is an aging population. If you look just at the single homeless adults, so not moms with kids, not the very young adults, obviously not the kids, almost half at any one time now are 50 and older. And what we found through our research is by the age of 50, people experiencing homelessness have health profiles much more similar to what we think of as people in their 70s and 80s in the general population. And so that means not only a higher burden of chronic health illnesses, diabetes, high blood pressure, having, congestive heart failure, cancer, but also functional disabilities and cognitive disabilities, more cognitive impairment, early dementias, things like that. The second thing is that people's health overall is incredibly poor, whether they're young or old. People rate their health as very poor, about 3 or 4 times higher than we would expect. And that one question is a very good predictor of people requiring hospitalization services or even dying. And then I would say there is a high burden of substance use and mental health problems. Again, because of this bidirectional nature, we found a large proportion of people who use substances started using after they became homeless. On the West Coast, we're really talking about methamphetamines as the driving substance. And it reminds us that stimulants are actually the main substance of use, and that is the substance use problem that we have the least effective treatment for. But what we saw is much disabling substance use and mental health problems, not at all universal, but it's there. And what we heard from people were the many, many barriers that they faced in trying to get treatment for those problems.
Yeah, you laid out a lot there, and we understand the complex intersections of all of these issues: chronic health conditions, acute medical crises, mental health, substance use, and they feed each other. All of them are made worse by homelessness. All are stabilized and helped by the foundation of housing. Will, in your role as a board member, as an advocate, as someone who's helping lead and guide care for the homeless, what do you see when you think about the health needs of people experiencing homelessness? What comes to the top for you?
Well, there are a couple of things that immediately come to mind that I think we're starting to touch on. Also, the model of the patient that's receiving care is changing, but how we treat those patients hasn't really yet. There's a lot of gaps that are just created by how we're choosing to go about treating people right now. We've also gotten to a spot where, hey, look, it's we want to make sure that we're getting folks care, but we also haven't progressed on to this point of how do we address people that need specialized care, right? It's already difficult to receive specialized care, but but what's the carve out for folks like me or the people that we're serving here at Care for the Homeless? I think there's also some gaps when it comes to what the follow up is. A lot of times we do a really good job uh, doing our best when folks are in shelter, but it kind of drops off a little bit once they're in supportive housing, and then it drops off a bit more once they exit supportive housing to housing of their own. What are those? When we're doing a lot of the work with the foundation and support while we have folks in our care, what does it look like as they start to transition out? One of the more frustrating things in the work that I do every year, we help co-lead a day of recognition for those that have experienced homelessness that we lost, our Homeless Persons Memorial Day. And working over the years, the amount of anecdotes that come with issues with healthcare or follow-up care or the lack, and we're, not to be negative, but we feel really great sometimes about how far we do help folks progress, and then we're kind of hands off and then we lose those folks, and it's a problem. So just circling back to the idea of we really need to progress how our model of care for people experiencing homelessness to address the actual population that we're now serving.
Just to pick up on a couple things you were saying, the need for specialty care and good continuity and good access is even more critical as the homeless population continues to age, right? We know that older folks just need more specialty care. People whose bodies have taken the toll of the streets for many years often have accelerated chronic illnesses and things that do require specialty care. So I'm glad you talked about that. I'm also really grateful that you brought up um, the homeless persons memorial days. I've participated in those around the country for the last 28 or 30 years, and it is continually heartbreaking, infuriating, uplifting. It's all of those things as we're remembering and honoring people who have died and wrestling with the frustration that it didn't have to be this way. We should have no one dying on the streets of a nation as wealthy as ours. So I appreciated you naming that. I'd like to shift gears a little bit and talk about the policy landscape. And Barbara raised this. I'm going to open this part up to Barbara and to the deputy mayor. As the funding and policy landscape is shifting, what are you most concerned about when we're thinking about the care of people experiencing homelessness? And either one of you can start and take it whatever direction you want. But we know we're in a rapidly changing, very uncertain landscape. We know there are Medicaid cuts looming. There's a lot of kind of rapidly changing policy shifts at the federal level. How are you contending with that, and what are you most concerned about?
Barbara, so I don't know if you want to go first because you can talk about FQACs and how they're managing.
Oh, I'm happy for you to go. Yeah.
So for us here in the city, HR1 is something from day one when our administration started, we started working on like what's going to be our response, what are going to be the effects directly to our New Yorkers, what are going to be some of the consequences that the policy is not seeing, trying to be ahead of the situation. How do we make sure that to quote my mayor, that we're not quarterbacking this, which I still don't, I have a son in American football. I still don't understand the term, but it's like, how do we get ahead of it? And we want to make sure that we're proactive and we're making sure that our New Yorkers are being understanding of what HR1 is really affecting them. When we tell people you could be one of the 600,000 individuals that'll be affected by HR1 Medicaid, or you could be one of the 120,000 ABODs that are going to be affected by the SNAP work requirement, and educating, because if you're not, probably a loved one that you know, whether a friend, a caregiver, will be affected by this work requirement. And then we're also trying to make sure that we're giving all New Yorkers the tools to make sure no one falls off. And when we're looking at our homeless population, sadly, they're not exempt from the work requirement either on Medicaid or on the food stamps. So how do we work with our non-for-profits, making sure they have the tools, that they understand how to fill out the form, that they understand how to make sure the form is given to HRA, to make sure no one falls off from their benefits. But more importantly, I think our biggest tool here in the city is making sure that we're advocating, we're educating. Um, right now, one of the cool things that we're doing a door campaign. And you would think in this moment, we're like ICE and immigration status and you not being welcome, us knocking on the doors could be very important, or seen as intrusive. But the fact that we're coming in there and saying, hey, trust government, trust New York City, and let me give you the tools, whether it's like sliding it under the door or giving your phone number to call if you have any more questions. We want to make sure that we're facing HR1 faced on and making sure that the most vulnerable don't fall off. And we're making sure the not-for-profits have the tools they need. We're making sure their neighbors have the tools that they need to make sure while we're fighting on the policy side that this is the wrong thing to do to address Medicaid and SNAP, we want to make sure that when we're fighting this, New Yorkers have the tools to make sure they're meeting the work requirement, making sure they're filling out their forms, and if they do fall off from any of their benefits, that we have the non-for-profits making sure they get back on.
Thank you for laying all that out. And for those of our listeners who are not in the weeds of this every day, when we talk about HR1, we're talking about the federal law that is also known as the One Big Beautiful Bill Act, One Big Beautiful Bill Act. I have a hard time letting those words roll off my tongue, but that is the official name of it. And within that act that was signed into law last year by the president. There are severe Medicaid cuts coming. There are work requirements that the deputy mayor talked about. There's the mandated more frequent recertification. And I think a lot of us are very concerned, rightfully so, that many millions of people will lose their health coverage as a result of these changes. And organizations like Care for the Homeless are in the position of having to navigate that both financially around Medicaid reimbursement for the care they're providing, but also helping the people they serve navigate these changes, understand what's coming, do our best to make sure that as many people as possible can maintain the coverage they have. Barbara, you're in this every day. What are you seeing? What are you thinking about? And what are you most concerned about?
Yeah, thank you. I want to come back to what Will had talked about in terms of the kinds of care that we've been able to connect people to and combine that with what Dr. Arteaga had mentioned. So we've just come such a long way in the last 12 years. So since the beginning of the Affordable Care Act's effective implementation of the Medicaid expansion, in expansion states and healthcare for the homeless, we started that at about a 50% uninsured rate. And in expansion states, we are now down to 20%. And that is incredible in terms of not just extending a benefit to people, but to extending more comprehensive care. There's a limit to what we can do in a primary care environment, although we can do a lot in a primary care environment. But in order to connect people to that comprehensive care that Will was talking about, specialty care, so that people can see cardiology, they can see neurology, they can actually get some of the chronic health conditions that many people have struggled with for many years. And to Dr. Kuchel's point, possibly contributed to them being homeless or unstable or unable to work, we can actually get those fixed. We can improve people's not just health outcomes, but their quality of life, their wellness, their ability to be able to live their lives in the way that they see fit and fulfill their own potential, all of the things that all of us want to see. And I'm just really concerned that we're going to have a tremendous backsliding, not just to the degree to which we can keep people insured, but the degree to which we in the healthcare for the homeless space can continue to provide comprehensive care to the patients that rely on us to both deliver that care and organize that care. And so this is something that I'm looking ahead to. And then I also just think that it's important to come back to looking at people's health holistically. I think we tend to talk about homelessness and health strictly in terms of mental health and addiction. And I'll admit that that's a little frustrating for me because we see that people come with their whole bodies. And so that means diabetes and asthma and cardiovascular disease and high blood pressure and infectious disease and all of the things that all of us bring into this can't be just approached from a single diagnosis perspective. And so what I really appreciate in this panel and in the work that we've been able to do in the last 12 years is really increase that coordinated comprehensive care. And I appreciate that. I anticipate, Margot, that you'll appreciate me saying that even when we talk about mental health and substance use, often those conditions started after someone was homeless. And the research shows this consistently. And so again, thinking about approaching health holistically, keeping a benefit that allows us to be comprehensive, and frankly, looking at this kind of from on all hands on deck from a perspective of providers.
And this is sort of for perspective on this. I got into homelessness outreach and healthcare work in the early mid 1990s. And at that point, if I'm remembering right, we had something like 45 million uninsured Americans. I mean, the numbers were astronomical. They're still way too high. I think the last number I saw was that we have 26 million uninsured Americans. But the Affordable Care Act, and Barbara points to that 2012 kind of pivot point. You can look at Massachusetts with Romney Care, a dozen or 15 years before that, where we went from almost no one experiencing homelessness covered by Medicaid to a whole bunch of people covered by Medicaid. And that really reshaped how programs are financed, the level of care that can be provided. To Will's point earlier about access to specialty care, it just opened up all kinds of possibility. And the biggest concern I have right now is certainly that people would lose their coverage and that healthcare for the homeless programs will have to navigate some very difficult financial waters around this as their funding goes down. But my biggest concern is that people are going to die. That people are going to die for lack of care for lack of coverage. And this is what we were doing 30 years ago, and we're taking this enormous step backwards. And I think you all who are on this panel and you all who are listening to the webinar, you all are the front lines in this. You're having to navigate a very, very challenging climate without a lot of great answers. We're going to look at some bright spots and what's working, and this won't all be doom and gloom, this conversation, but I think we cannot sugarcoat the damage that is going to be done as people are just kicked off the Medicaid rolls and are stripped of access to care. Even as imperfect as our current system is, it's covered a lot more people and allowed a lot more people to get the life-saving care they need. And that really is on the verge of being reversed. Deputy Mayor, I'm glad you used the raise hand function. That's very civilized. Why don't you go ahead?
No, I just wanted to mention, stepping back where we were like 10, 15 years ago. And if we remember our emergency rooms, as a hospital CEO in my prior life, one of the biggest things is having your emergency room so overwhelmed, but it's not overwhelmed with the right patient. Is overwhelmed with like things that should have been done at a primary care level, like the uncontrolled diabetes, the hypertension, bad medication management, asthma attack. And then at the same time, you have like people truly having like strokes, high acuity, and those two mixes makes the hospitals, the doctors overwhelmed, causes it a lot of backflows, and that's where mistakes happen as well because you're already on an overwhelmed system, already bringing additional flow like that is gonna make, and with the workforce getting smaller and smaller in the world of medicine, it's just like, you can have one doctor with a resident, managing 40 people right now. Now you add those that are
Mhm.
not going to start using ED like primary care centers again, like we did 15 years ago. You add that ratio, that's two an attending and a resident to like 50, 60 patients, mistakes will happen, delays will occur.
Yeah. I think you're right, and the reality is we as a nation are going to pay for the care either way, and
Yes,
we
sir.
have for a long time. We're either going to pay for it in emergency rooms or long-term care that could have been prevented, or we're going to pay for it by providing people health insurance and primary care and access to the more preventative work. So thanks for raising that. Margot, go ahead, and then after this comment, I'm going to pivot to another topic.
I mean, it feels like so many things we're experiencing, we're going backwards in time on so many issues, and this adds to it. But I think a few things I'll point out: the work requirements and the paper requirements at HR1 almost seem designed to imperil people experiencing homelessness. They are such an enormous administrative burden, and one of the things we know about when you're surviving homelessness, doing paperwork, getting mail, like all of that is so terrible that this is like an extra barrier. The second thing I'll say is HR1 is imperiling not just our healthcare for the homeless systems, but our budgets, our municipal budgets, our county budgets, our state budgets in such an enormous way that are in fact affecting all of our services, like indirectly. States and counties and cities are taking such a hit from, as Dr. Arteaga say, they're going to need to do all this uncompensated care. It's blowing a hole in their budgets, which is then going to limit their ability to have flexibility to do other evidence-based things. And then the third thing is, I think what we're really seeing is a retrenchment to the bad old days. It wasn't like some of us have been through all of those days where, meeting people with healthcare, the homeless was often really doing triage. And we actually have moved to a place where we can actually manage conditions the way we might want to, not perfectly, but so much better. And I worry that we're in the same way that we're seeing this backtracking on so many other rights and so many other parts of our society. We're really taking what has been tremendous progress and undoing it. And it's going to take us concerted effort and time to just back to where we were. I'm not sure if the public realizes what a transformational change things like Medicaid expansion, Medicaid waivers that allow for us to pay for some things that are so integral to people experiencing homelessness, and how much we're going to be moving backwards with this.
Yeah. As I said, I'd like to shift gears and talk a little bit about cross-sector collaboration and the importance of working across systems. I want to remind our listeners that we want you to submit questions for our panelists. You can use the Q&A function in the Zoom meeting to do that. We've got a team who's sorting through those, and we'll save some time at the end for opening the discussion up to your questions. Will, I want to start with you on the question of cross-sector collaboration. We know that the health systems and the health sector are critical to address homelessness. And we know that the health sector alone can't solve homelessness. It also involves housing. It often involves um, the education system. If we have families with children involved, it involves the carceral system and jails and prisons and courts. It involves job training and support. It involves community programs of all different kinds. When you've seen things either work well or not work well, how do you think about all those systems interacting with each other?
Yeah, it's absolutely a lot, right? And it's interesting because I think I have perspective on both sides of the conversation, right? When you're experiencing the trauma of homelessness, right? It's just like any of us when we get an injury, you don't want to have to keep reliving that injury, right? But a lot of times the way the systems work, I've got to tell the story of my trauma 5 different times to 5 different agencies in order to get care, and that's not helping. So this idea of what does the communication look like? How do we do intake? How do we do an intake? Are we treating the whole person? When we have situations where both the case management and the healthcare, or potentially the psychological care and the housing search, like all of those systems all of those folks are all working together to address the needs of the person experiencing homelessness. It's just a remarkably different experience because all of those areas impact my day to day well being, right? And so if I'm not feeling particularly healthy, right? That might be something that's communicated to my case manager and the housing specialist, and now we reorganize whatever my appointments look like, or who I need to go see, or if I need to have a pep talk, right? But it's the full commitment to help me continue to navigate my ways through the system. There's also this idea that when we're thinking about healthcare, it's a very intense and personal relationship, right? So when we're talking to our doctor, or we're talking to someone who we're working with, when we get that referral, when we get that whatever to someone else, it's like, well, okay, well, I'll extend my trust to that person because I trust you, right? And so like there is that idea of making sure that, hey, I understand both the capacity that I'm serving in, but also how the system that I'm serving in works. And so here's who I need to direct you to so that you can continue to get the care. Because again, in all of this, the underlying thing is trust. And once I stop losing my trust, I stop maintaining my healthcare altogether. And now I'm back, I'm back to go, right? And I've lost my $200, right? So the more that we continue to have these conversations, you're not directing someone to a hotline or giving them a sheet of people, of folks to call through. Because a lot of times we're dealing with folks, again, who haven't really been proficient in managing their healthcare to begin with. So the more barriers that we put in place, the less likely they're going to follow up with it. And that's that long-term thing. One other item that just comes to mind though is just also addressing the idea of some of the stigma that still comes for folks experiencing homelessness using this system. Us on the panel, I'm assuming the majority of us on the call, we're attuned and aligned for doing this work. But for other people, the job is the job, right? And it's a very distinct community, right? When you're addressing it as just the job, sometimes it's very informal. Sometimes there's an assumption. Sometimes there's the, hey, you're an uninformed, I'm now going to treat you like an uninformed patient, which doesn't work very well in the long run for all of that too. So the idea of the intentionality with which we approach a lot of this, I think, is very important as well.
Thank you. Nicely said, Will. Deputy Mayor, I know you're relatively new in this job as the Mamdani administration came into office in January, but you've been in this work a long time, and you've led health systems. You've seen a lot of these challenges of working across sectors, and I'm curious how you think about the barriers that get in the way of good cross system collaboration.
Um, I've only been in this role 5 months, and I can tell you that silos don't work. I think one of the major things that we're trying to do in our new era of administration is breaking down those silos and working with, like, even just data sharing, like going back to like the beginning, how like I under me, I have 16 agencies. I can't have DSS share data with health and hospitals. I have to do like 3 billion pieces of paperwork. Right. But like, how do I break those silos down? Like, how do I talk to law and be like, hey, this doesn't make sense? We're the same city, we're the same agency, or how do I get data from runaway youth, right? Because again, trying to be ahead of HR1, like, right, a lot of my youth that are emancipated, that are living on their own, or that are in shelters, they also fall into the work requirement. But how do I get to them, right, if they don't have an address? How do I get to them if they don't have a cell phone? Right? I have to get them through my non-for-profit providers, but sharing the data, it gets tricky. So how do I break those silos down? And again, sitting down with like my not-for-profits, working with my FQACs and saying, okay, like what do we need to at least let's share minimal data? And that's what we're trying to do here as a city is like, okay, seeing like this is a barrier that doesn't make any sense. Okay, let's work with the people that can remove those barriers and let's try to expedite. Let's push. And the pushing can sometimes make people uncomfortable. But we're committed to making sure that if there's anything we do within these 4 years, is leave the city or the agencies that are under the city's profile, um, to at least be working together to be sharing a lot of the information. Because again, it makes no sense that DSS can't share data with youth or aging, right? We don't need 3 billion lawyers to have that work. It should be seamless. And that's what we're trying to do to reduce some of this silo and going back to Will, like making sure that if you're a youth and or you're a parent in our shelter system and you have an ACS case and you also have a teenager, how do we get instead of 3 agencies, 3 social workers, how do we get one case manager to manage all of that for you? Because one of the sad things that we have to be very self-aware when someone is in crisis, the worst thing you can do is give them more. You think you might be helping them, give them 5 social workers, but it's more overwhelming. And then the client or the patient gets more deeper in their crisis and just wants to give up. And that's not the goal. That's not the goal we're trying to do.
I appreciate your leadership on trying to bust silos and get these systems working better together. And I can relate. My job with the Biden and Harris administration was to coordinate the homelessness response across 19 federal agencies, and
Ah, Dios
I
mío,
think I
so you
still have
know.
the scars to show for it. It's incredibly hard to do. I mean, these systems often grew up not really centered around the person, but much more centered around the system itself, whether that's the way Will was talking about having to tell your story multiple times to get the help you need, or even just something as simple as how a transition works from city jail to an apartment versus just out onto the street. I mean, these systems break down, and the human beings moving through those systems don't fit in those silos. They live complex lives that cut across all kinds of things, and yet we've designed systems that really fail people in many ways because of that. I'd like to turn it a little more hopeful, and the question for all of you, and Barbara and Margot, maybe we can start with the two of you. But I'd love everybody to weigh in. Where are you seeing some bright spots around this? Are you seeing places that are actually doing good cross-sector work? And it could be small, it could be a pilot project somewhere, or it could be more large scale data sharing or coordination or better transitions of care from one system to another. What are some things that are giving you hope around this cross systems work these days? Margot, you
Do you want to go
unmuted first.
first?
Go for
Oh,
it.
okay. I
Okay.
mean, I think one system that it's almost been too quiet about their successes is a VA system, which in some ways was set up well to do this because the VA health system is really our closest thing to a sort of true access, organized healthcare system where they can implement changes quickly. And because of the status that veterans hold, it's much harder for electeds to come out against veterans. And so they had funding to do this. So I think looking at HUD-VASH, looking at the way that they organize the VA healthcare system to be a place where people came, where they could be identified as needing help with either prevention or housing, where they could be triaged, and the way that the VA health system has stood up to provide some of those services is a big part of why veterans homelessness decreased by more than half in a period of time where homelessness in other sectors was increasing. I also, speaking from a California standpoint now, am seeing hope with our Medicaid waiver, our 1115 waiver, and trying really to get the healthcare system more aligned with these other systems. It has not been easy, and progress is slow. But because Medicaid managed care plans, which is how we manage all of our Medicaid payment now, bears some responsibility for contracting for case management services, for housing navigation services, has the ability to make, modest investments in the things that keep people from being housed or threaten their housing navigation, housing sustainment services. We have a huge state, and this is really done at the level of the county where our Medicaid funds flow through. But we've seen some counties that have really been able to better coordinate their systems, in part because the funding was aligned, and in part because almost through brute force, through lots of trainings, lots of, bringing people, convenings, bringing people together, asking them to speak the same language, we are starting to see progress.
Great. Barbara?
I think I would start by saying that part of the reason why the HUD-VASH initiative was so successful is because the VA is a singular healthcare system with singular support services. And there's generally only one housing authority in a community. But contrast that with outside the VA, you can have hundreds of providers. You could have a dozen managed care organizations for care. And coming back to Dr. Arteaga's point is that the fragmentation in the system really undercuts the kind of outcomes that we can all achieve. And so I would love to see kind of us focus a little bit about how we might be able to simplify our system. But given where we are, I think what I'm hopeful about here in the collaborations that are currently happening, right now, all states are scrambling to figure out how they're going to work HR 1 into their Medicaid systems, which are generally held together by bubblegum and duct tape. And so this is the kind of thing where co-locating services, much like Care for the Homeless co-locates in shelters with its medical care, sharing not just your data, but your stuff in general, your space, your staff, your data systems, being able to have insights into each other's systems to be able to do better data coordination that leads to better service coordination. And then having the funding support that is really helpful. I know, like, for example, in medical respite care, programs that are designed to help people experiencing homelessness coming out of hospital systems do rest and recuperation and all of that. An example is in Yakima, Washington, where you have the COC, you have hospitals, you have payers, and the FQHC all working together to make that model work well, but the systems all support each other in that work. And I think that's a model that other communities can adapt, particularly as homeless services increasingly grapple with how to meet the healthcare needs of the clients they're serving. Medical respite programs, healthcare providers broadly, can really be a natural collaboration there to make everybody's job easier, as well as yield better support for all the clients that we're serving. So I think there's a lot here in terms of like Medicaid and the reauthorizations that we all are going to need to collaborate on. So how can we bring homeless services as a partner into the redeterminations of Medicaid dates, having insights into when those dates are for the people we're serving, as well as in the service delivery space. I think just there's a lot of bright lights happening. I really am hoping that continues.
Thank you for those. And Deputy Mayor, I understand you're going to need to peel off at 2:30 to help go run a city. Is that correct? That's what your team told us, I think. So we've got you for about 10 more minutes, and then we've got everybody else for the rest of the time. So I think what I'd like to do is take one more question where we kind of do a lightning round for the group, and then Deputy Mayor Helen, I'd love to give you a chance to offer any closing thoughts for the group before you have to step away at the half hour. Does that make sense?
Yes.
Okay, so the question is really the topic today is around the future of healthcare for people experiencing homelessness. We've talked a little bit about the past and a little bit about the present. I would like you all to sort of put yourselves into your future state, your kind of imagining what's possible, thinking about innovations you're seeing now and how those could be scaled, even in the context of the policy changes that we've been talking about. And I'm curious, and Dr. Arteaga, maybe we can start with you on this. What do you see as some of the best innovations out there, and what do you think is possible as we can contemplate the future of these issues?
So I hope to, and we're doing the groundwork for this. I hope to see more shore vans, which are these mobile units that we have here in New York City that are literally where our patients are, where our clients are when they're unsheltered, right? When they're in the encampments, as we call them. And these mobile units are equipped like mini medical rooms or mini exam rooms with nurse practitioners, PAs, and where they can give real medication to the patients. So I'm envisioning that. I'm hoping that I'll have like 10 bridges to home, which is in a program that takes individuals from the hospital that need a little bit more care, and who have severe or high level of acuteness of like either substance abuse or behavioral health issues, and we bring them to a supportive housing that it's like a housing with a nursing station on every floor, basically, bridge to home. And that is a huge thing. And I hope to see that in the next couple of years, we've made the application of whatever voucher program that we have to make sure that we're exiting as many patients as we can when they're ready. And when they're ready to leave our shelters, that the voucher applications that we have currently in place, that they're easy and streamlined.
Great.
So I'm
Well,
hoping
we're
for
going
a lot of
to.
stuff.
No, that's great. It's helpful, and there's something very just practical about the shore vans that you're talking about, and taking healthcare out to where people are. Will, when you
And we
think
saw
about
it during the code blue. Sorry to apologize. We
no,
actually
please.
saw it in the midst of the Arctic winter that we had in New York City. I don't know if, because now it's nice and hot, so we don't quite remember. There were days in New York City that was colder here than in the North Pole. And what we notice, a lot of our communities that are in the unsheltered world, right, that are not in our shelters, that are afraid to come in, we saw the show vans, these mobile units, be the first step of trust, like Will was talking about. Like, if I don't trust you, I'm not going to go in a shelter. I'm not going to ask for help. So these show vans show that we can go to our individuals that are unsheltered and say, hey, we understand you don't want to come into our shelters. You don't trust us, but can you just come into this van? We'll give you some socks, some tea, and at
Yeah,
the same time, can we check your blood pressure? Can we check your
yeah,
medication? And
great,
if you need it, we have it right there and there for you.
great. Let's do this as if we can, just kind of in a lightning round, like 1 minute. Will, then Barbara, then Margot. What do you see as future possibility here?
Okay, I'll be quick. I think just continuing to maintain the flexibility and pliability that we have in our care models, realizing that the patients that we're treating in their lives are inherently unstable, and building that incorporating full community models kind of centered around the community healthcare center, co-locating as much as possible. But all of the different programs, we're kind of super specialized and have niches, are working together within the community to support those that are experiencing homelessness, also kind of speaking to defeating those silos. But probably also super personal for me is the intentional application and use of folks with lived experience, whether just as advocates or as peer support specialists. There's just an extra bridge that we're going to have that no one else is going to have because we've been there, done that kind of deal. Whether it's part of the conversation encouraging someone to come inside. There's a level of trust that we're going to have that might be better than the regular outreach worker. When it comes down to, when it comes down to having certain conversations, well, hey, you know what? Like, your best patient is going to be an informed patient. So talk to them this way, that way, the third. But also just making sure, even within that it's, as much as we're doing really good work with adding and elevating folks using their voice to tell their stories, also within that same group, finding those really trusted messengers that understand all the aspects of this conversation that can help us to continue to amplify the message and do the underground education work in the community as well.
Great. Thank you for raising the issue of the leadership of people with lived experience. I think the healthcare for the homeless movement broadly and organizations like Care for the Homeless in New York specifically have been leaders on this for decades of having people with lived experience as outreach workers, peer specialists, recovery coaches, board members, advocates. The National Healthcare for the Homeless Council has a very powerful national advocacy board. We're seeing a number of other movements around the country really raise up the leadership of people with lived experience. I think we've learned a lot from the youth homelessness space on this, where youth action boards are doing just incredible systems transformation work around the country. And as Brian Stevenson would say, it's the people most proximate to the problem who have the best answers to the problem. Those who have seen it, those who have felt it, those who've experienced it are going to know best what the solutions are. So I'm really, really glad you raised that. Barbara and Margot, just very quickly, what's an innovative direction? What do you see as the future of this work?
One of the things that I'm focused on is just the technology that's getting better and better really, really fast. So not only do we have better technology as healthcare providers with our electronic health records that can connect to lots of different systems, that we can be able to be delivering care across broader spaces through those systems. So I'm excited about the technology that we can have both in the clinic and on the street that allows us to deliver that same kind of care. I'm also interested in better medications that are coming on to the market, medications that allow us to treat chronic diseases that we haven't been able to treat for a long time much more effectively in a primary care environment. So that's exciting. I'm excited about better data. And while I am concerned and have a lot of concerns about AI, I do think there are some promising practices here that can improve care. Again, I think there's a lot of emerging guardrails that need to be put in place here. And frankly, I'm seeing a lot of providers that are just new to care, that are coming into this work interested in street medicine, interested in homelessness, interested in non-traditional ways of delivering care. I'm just really excited again about the younger providers, new technology, and better medications. I think that's really going to be helpful for us.
Great. Margot?
I was going to say all of those things. So you took the words literally right out of my mouth, but maybe I'll use my time to add on to give a vision of how those could be used. I think that the new technologies, whether it is sharing data, whether it is telehealth, the new medications, depot formulations, medications that only require people to get the medication once a month or once every 3 months to get the same effect, and the energy of new people and the recognition of the importance of lived experience will hopefully, with funding flexibility, allow us to provide the right care in the right place. Things like alternative care provision, things like sobering centers and recuperative care, where we can provide that care outside of hospital settings for people who need that. Things like increase in street medicine and really being able to get out to people if they are not yet in shelter. And frankly, the ability to flex our care to bring it into housing so that people can get the full range of care. We have for too long in the health system, ask the consumer, ask the patient to come to us in those rigid ways that we are. Here's your psychiatry office. Here's your primary care office. Here's your, GI office. And I'm really hoping that we can look towards a future where we are more consumer patient centric, where wherever they are is the right place to be. And we are the ones who will move to meet them where they are and to meet their needs, whatever those needs are and wherever
I think
those needs are.
it's going to be a really nice place to pick up in our audience Q&A. We've been seeing some questions come in, so we'll come back to that in just a minute. Deputy Mayor, I know you're going to have to go. I just wanted to give you a minute or so to offer any closing reflections before you step away.
The only thing, I know what we have ahead of us is very hard work. But I'm very confident in the work that's ahead of us. I think we're all coming together, having these type of conversations and these panels. I mean, you have over 180 people signed on to listen to the great work that you all have done. And the fact that we're willing to have these discussions on how to learn better and how to get to the solutions quicker gives me so much hope that we're, as a city, we're going to manage this together. And our goal to make sure that every person that's in our shelters gets to the right place where they right need to be to make sure they stay successful. I'm very hopeful, but I'm hopeful, but I know we're full of action. So if there's anything I can do, the city can do to continue supporting, please reach out. I'm here to support and get the work done.
Thank you for taking the time to be here. Thank you for your leadership, and let us know how we can support you in the administration in doing what you're trying to do as well. Thank you for everything that you're doing to serve the people of New York.
Bye, everybody. Have a great session.
So I think we will pivot now to some audience Q&A, and this can be a little more free flowing. I think if you all have thoughts that you want to weigh in on, if you want to even ask each other questions, that's fine too, based on what we've heard so far. One question, Margot, that I'm going to direct your way. This came in from the audience, wondering what the panel thinks about telehealth and in circumstances when in-person visits are really challenging, and then there might be issues around what's covered by Medicaid and that sort of thing too. But could you just give your thoughts on what you've seen work and what some of the pitfalls are around telehealth?
I mean, I think telehealth has been a game changer. I think really the pandemic really sort of exploded our ability to do this. And once we started to do it, we sort of kept going. There was that brief month where Medicare wasn't paying for it, but then Congress came back in session and actually it was recognized. And so we are back to being able to use it quite expansively. And I think we have a good sense now. There are some things that have to be in person. You can't give someone, an injection when they're not with you. You can't do a great physical exam when they're not with you, although you'd be surprised what we can do. But so much of what we do in primary care and specialty care and mental health doesn't actually absolutely require that someone be there. We've seen great outcomes even with buprenorphine, with getting people started on medications for opioid use disorders, for mental health care, for primary care. We're seeing a lot of use of telehealth for specialty care, because often the problem we have, particularly with things like Medicaid funded specialty care, is that there are not that many providers. Definitely true in rural areas, but even in urban areas. And if you can save the time, sometimes it's provider to provider. We do a lot in my safety net setting, where as a primary care provider, I can message a specialist so that the patient doesn't have to go there. And the specialist can say, hey, this is what I would do. I would draw these tests, I would do these things, and we can communicate. I think there's enormous potential here. Now, obviously, one of the barriers for people experiencing homelessness is they often lack the basic, if you don't have a cell phone, if you don't have internet access, if we require that. And so I think that's where we need to work. But we're seeing exciting things about, let's say, street outreach workers, people with lived experience going to where people are with their iPad or with their thing and helping plug someone in. I am very, very bullish on this as something we need to lean into.
And it is 2026, for God's sake. Barbara, go ahead.
I wanted just to also mention how important telehealth is going to be in a world of Medicaid work requirements. And so, for example, a chronic disease management check-in to make sure somebody is doing well on their insulin, their blood sugars are good, the whole bit, like that's a 10-minute visit. And if someone can take a coffee break at their job, step into a space where they can check in with their provider on the phone, get re-upped on their insulin or other medications, make the adjustments they need, and then go back to work without having to take leave, that is tremendous game changer, not only for keeping your job, but also keeping your health insurance under the new rules. So I just really see telehealth as being not just something that delivers better care, but that actually keeps people covered and keeps people reimbursed.
Thank you for that, Barbara. Will, go ahead.
Super quick there, because I find myself in the position of wanting to mention the point that I usually don't cover. I'm usually the one that's trumpeting all the benefits. But as great as what you were both talking about, Marlo and Barbara, is, and how innovative it is, and the access of care kind of makes people like me feel more normal, because that's how a lot of people are accessing their care these days, and I want to fit in too. Is just making sure that we put out there the fact that making sure that providers are compensated properly for that. The inequity for the compensation for telecare, while it's great for us, doesn't make it worthwhile necessarily or in the best interest of the provider. So that needs to be adjusted. Again, when we're talking about the flexibility of how we're addressing folks, that just, I just want to just make sure as much as we're trumpeting that, we carry the other piece of that as well.
Great. Thanks for raising that. Barbara, I want to go back to the thing we bookmarked during your opening remarks, which was, you made the statement about how important it is to integrate service and advocacy. And this is a conversation you and I have been having for decades, I think, along with a lot of our friends and colleagues in the healthcare for the homeless world, and with Susan Nybacher and Bobby Watts and Donald Whitehead, and you like integrate all this stuff. You can't just do the day-to-day work of providing care for people. We've actually got to be changing systems. We've got to be changing laws and policies. And one question that came in is related to that. And this, Barbara, will start with you, and I'd love to hear Will and Margot's thoughts on this too. How can we better show the impact of healthcare for the homeless programs through our data and storytelling?
I think, first of all, thank you for the question. That's absolutely the direction we need to go, is uniting data and stories. I think, frankly, we need to be more confident in getting out there and telling our story. We need to be talking more about what we see as direct providers together with the patients that we're caring for. I'm coming back to the people who are closest to the problem are the people who are going to be driving the solutions that work. And so I just feel like when we are in a service space, we can speak to the work that we're doing every day. This is not an ivory tower perspective that we're bringing in, and we know what works and what doesn't. And frankly, I'm excited about the role that healthcare providers can play broadly, healthcare for the homeless specifically, to educate policymakers about what this looks like, because they're not in the exam room with you. They're in many cases not even the same neighborhoods where we're working. And so for us to help policymakers illustrate the challenges that are happening in communities as well as in healthcare, I think that's the only way that we're going to be driving the kinds of policy change that not just ends homelessness, but improves our healthcare systems and our communities broadly.
Will, Margot, what would you add to that?
Well, yeah, I was just thinking one of my favorite things about the work that I do here with Care for the Homeless is how we're really working on perfecting our model of having our policy folks come in with the data, and then having, whether it be CAP members or other lived experience advocates come and have the anecdotal, evidence to support the data. And it's just been such an effective 1-2 punch in so many conversations, because on either end of the spectrum, it becomes an education piece as well, right? Here's the physical numbers. If that's what you're into, if you're touched by the emotion and the experience of someone, here's that, right? But it's also just, I think it's just important to not when we're talking about putting the two together, to not limit our advocates to just the stories, right? Again, when we're talking about addressing the whole person, I didn't know that I was going to have a lean for policy until I started having a conversation with the folks that were working policy. I'm like, oh, well, that matches my corporate background, and I get how that and that works together. So now, here's this other piece of my story that I can add to that, right? That doesn't even necessarily have to be just about the time that I was in shelter or this, that, and the third. And it just becomes that much greater of a relationship. And it also, I think, it helps to address a lot of the barriers that people that we're interacting with still have for people that are experiencing homelessness, where we just limit them to this certain thing. It's like, you know what? No, we're regular people, and we're just as effective as anyone else in this conversation with the proper coaching and training.
I love all of what you said. Just to pick up on a couple things. One, that people are bigger than their stories. The stories are incredibly powerful and can be useful tools. But when we limit our thinking to, okay, here's somebody with lived experience, tell your story before the city council or before the state legislature or in a public setting, as opposed to saying, Will, you are a multifaceted, skilled, complex person who happened to experience homelessness, and you can bring that experience to the table, but you also bring your entire life's experience and skill set to the table. I think there's just such richness to that and such power in that. The other thing I just heard you say was that different people respond differently to different kinds of data, stories, evidence. Some people couldn't care less about the evidence. That's not how they make policies, including a lot of elected officials. But they might be moved by one story that really captures their heart, their imagination, their compassion. And other people are very analytical and need the data, need the return on investment on the finance side, and we need to be sophisticated enough in our advocacy to use all of those tools because they do work differently with different people and they interact differently with each other. So thanks for raising that. Margot, what are your thoughts on this front?
Yeah, I mean, I think to get back to sort of healthcare providers, I think we need to lean into our expertise and the trust, which has been slightly diminished, but the trust hopefully that we have with the public. I see so much mythology out there from people who clearly have never actually understood how these things work. I saw a prominent person talk about people struggling with addiction as having fun and partying. And what I thought is, well, you have clearly never talked to someone struggling in the depth of addiction. You clearly are showing that you don't know what's going on. We've seen such a backlash against well accepted policies like housing first. And I think even frankly in bright blue California, we're seeing that same pushback. And I think that we need to get out of our shells, learn how to use our voices. And that is a skill. Like I say to the researchers and the health providers, like as soon as you go to a policymaker and talk about a marginal structural model or even a p-value, you have lost the thread there. And I talk about evidence-based storytelling, rely on the evidence for what's true, but use the story to show it. We're not going to use anecdotes to drive policy, but we are going to use stories to show our data. And then I think we need to be fearless of talking about when policies and stories are leading us down the wrong way. I will say that one of the things that I have found really hard is this idea that all healthcare for people experiencing homelessness should be there to save money. And to point out that I understand how we got to this, but I think it's become very dangerous because nothing else we do in healthcare, that is not the metric we look for. We don't look at whether dialysis saves money. We don't look at whether cancer treatment saves money. We look at whether it improves people's lives. And I think you can get to a point where I'll give you an anecdote that just happened to me. I have cared for a patient on and off for over a decade who was in supportive housing, who had very significant delusions that are sort of from schizophrenia, very scary thought disorders that led him to do activities that caused a lot of damage to his building, led him to be outside. He was evicted because he caused $1 million of damage based on his delusion. He's been outside now for over a decade living with very, very, very severe psychiatric disease. But the nature of his disease doesn't cause him to use a lot of services. He's sort of not bothering anyone. He's not coming into the emergency department. He's not coming into the hospital. He's suffering silently by himself. When I went to our outreach teams and asked them to reach out to him because he's been showing some interest in that, they were forced to look in their records and said, well, he can't be on our priority list because basically he hasn't used a lot of services. And we are only allowed to prioritize people based on whether we can basically save money. This wasn't what they wanted to do, but it's where the policy had directed them. I think we need to be fearless about sharing those stories as well, and to really be clear on what our outcomes should be, what the truth is, and to not just sit in our exam rooms responding. We need to be out there speaking to the public, speaking to the press, speaking to policymakers to be sure that they really get information that's valuable and useful.
That's great. Just one last question for you all, and then we're going to shift to just closing comments. I'll give each of you a minute to give any final reflections. And this question has to do with the landscape of federal funding as funding is reduced as we get into these very complicated times. Margot, you talked about how this is going to impact state and local budgets as well, certainly as nonprofit budgets. Can you all think of examples of local governments or health systems stepping in to sustain services when federal funding is threatened? Are there any bright spots here where you're seeing great creativity or local or state leadership in the face of some of these federal changes?
I'll start by just saying that I am encouraged to see at least half the states anyway who are really trying to figure out how do we identify state or local funds, philanthropy, public-private partnerships, things like this to fill in the gaps that are increasingly getting larger, to be able to continue those services. I've also been really encouraged by states that have continued to, for the most part, stand by their added services and Medicaid, even though I think that we are coming up into a space where there's going to be tremendous pressure on states to cut back on those services. I think that's going to be a real disservice to the larger community, but also just to the kind of outcomes we're looking for. But I think that's what I'm looking at.
Yeah, I mean, I'd say the same thing. Like I see in California, really trying to think creatively, partnering with our legal authorities and with the, and with this data systems of how we can prevent the loss. I will say another thing that I find hopeful is it really is the Medicaid budgets that are blowing the holes in all the municipal budgets. And in California, and I've seen many municipalities, including San Francisco, that is not going to make the healthcare system bear all of those losses, if that makes sense. They're really looking where in their budget they can save things so that they can continue to fund as much of the healthcare services as they can, rather than saying, you're the ones who lost the money, therefore we're going to withdraw from all of these initiatives that we've been doing.
Yeah, those are certainly some important ways to be thinking about this. Will, anything you want to add to examples that you've seen around the kind of funding side of this? I don't want to put you on the spot, but I want to give you a chance to weigh in.
Absolutely put me on the spot.
Yeah.
I was deferring to my colleagues with more national experience, but I will say just maybe very briefly, just with some of the work I've done. We touched on it, but just some of the work that was done around the 115B waiver. Just again, being innovative, being flexible. Hey, if this is working and the answer isn't no, then let's keep pushing it. Saying we're going to push this as long as we can work with. And I think sometimes, if we know that again, just being a little risky. We're going to take a shot. We're going to see where this works. If we can't do it, we won't do it. But, I think you mentioned it earlier with some of the approaches that we're taking, we've been doing the same thing for 30 years, right? So, let's try something. Let's get messy. Let's make mistakes with it, so to speak, but just on the other side too, like, as someone that would be using these services, I don't necessarily want to know how the sausage is made, so to speak, right? I just want to be able to say, hey, I can get the healthcare that I need, and that's just one less thing that's fractious for me. So, like, just kind of also just embracing the trust that those of us that are receiving services are putting into some of this work, because that is so much of a value add for us, because we don't know what else to do without it.
Great, thank you. And I would just add on this topic, as federal leadership is creating chaos, is withdrawing funding, is creating policies that are incredibly harmful to people experiencing homelessness, it is on the shoulders of local leaders, both local nonprofit leaders like Will and George and Jonathan and the team that care for the homeless, on public officials like the deputy mayor who was here, and the mayor and the state legislators and the governors and the city councilors and county supervisors and all other local leaders to create something better. And it's a really hard context to be working in. But even as we're navigating some very damaging public policies, federal policies, funding challenges, we are also designing the thing that's going to rise from the ashes. And I think we shouldn't lose sight of that even in these difficult times, we have the possibility of reimagining. We have the possibility of trying new things. We have the possibility of envisioning what is going to come next, because something will come next and we better be ready for it. I'm going to turn to our presenters for just a rapid fire last reflections what do you want to leave our audience with? And I think we'll start with Margot, then go to Barbara and give Will the last word. Margot, what do you want to leave folks with?
Maybe I think sometimes we've seen over and over again in our field incredible resiliency in crisis turning into opportunity. And I hope that we can lean into what the great um, Mariam Kaba says, that hope is a discipline, and maintain hope in these incredibly trying times, remain committed to seeing a better way, and try to not only not lose momentum, but somehow throughout this incredibly difficult time, figure out a path forward. Because I do think there's going to be a tomorrow that's going to be better. And I think we need to just not lose momentum and keep supporting one another, listening to those with lived experience, and using this time as a time to come up with new innovations and keep moving forward.
Thank you. Barbara?
I'm thinking about just we deliver tremendous care in the healthcare for the homeless community. But if we think of homelessness itself as a bathtub, we're bailing people out of that tub as fast as we can, but no one's turning off the faucet. And that's not something that we can do in the healthcare space. And so this is where we need our public policies to support good care. Public policy is what produces homelessness faster than we can end it. It's public policy that needs to be changing so that we can be preventing and ending homelessness. Again, that doesn't come from us in the healthcare space. So rent either needs to be cheaper or people need to have greater incomes. Healthcare needs to be cheaper and easier to access and simpler to navigate. All of these things. And so I think as we move into, I think a challenging era for us, particularly in healthcare, I think this really raises, to your point, Jeff, what comes after. And I really would like for us to lean into the opportunity to revamp our healthcare system into something that more resembles any other country that we would want to be compared to. So that's one. And then second, I would just implore us all that as we're coming into this, please don't tune out. Don't turn away from the hard policy work here, because that's what's going to get us through, and that's what's going to get us to another chapter, hopefully that's better. So tune in, work with us on the advocacy, and please bring your voice to the table. This is an all hands on deck. Our work has never been more important than now.
Thank you, Barbara. Will?
That was remarkably well said. I'm now rapidly re-editing in my mind. No, I think I think we're acknowledging the difficulty of the situation we're dealing with. We're acknowledging some of the difficulties that are coming down the road. But it's also a reminder of situations and times that we've dealt with before, right? So there's a little bit of a blueprint there, which allows us the opportunity to work smarter, right? To be more efficient. Are we allocating our resources in the best possible way? Are we making best use of every resource that we have available? What are the conversations looking like? What is the communication looking like? Do we have an agency that's continuing to coordinate efforts in various municipalities with all the necessary stakeholders that are involved, so that the conversation doesn't get siloed and free flowing? And remember that we're being people centered, right? Are our metrics adjusted? It's not just how many people we're moving from place to place to place, but how much stability are we providing? How many lives are we saving? How many lives are we prolonging? Right? How many lives are we changing by what we're actually addressing, and let that be the move, and then using those folks that we are saving and re-empowering to help push the rest of our work forward. I just think it's just really important, even within the doom and gloom, to understand that we do kind of got this, but we do need to be intentional with our planning. We need to be very aware, and we just need to be a lot more efficient and smarter with how we do things, and allow us to continue to push forward.
Thank you, Will, and thank you to all of the panelists. You all have been spectacular over the last hour and a half. Really appreciate all the wisdom that you all have shared, the perspectives, the passion, the continued energy for this critical work. It's also been wonderful to just scan the participant list and see so many familiar names, and know that you all are out there leading the work in your own communities and nationally around providing care for people experiencing homelessness. And with that, I'd like to turn it to Jonathan Santos Ramos, the Executive Director of Care for the Homeless, to close us out.
Thank you, Jeff. And I agree. Thank you to all of our panelists, Deputy Mayor Dr. Helen Arteaga, Dr. Barbara DiPietro, Dr. Margot Kuschel, and CFH Board of Director and CAB member and advocate Will Woods for such an amazing and important discussion today. What we heard throughout this conversation is that healthcare for people experiencing homelessness cannot exist in silos. Improving outcomes requires strong partnerships across healthcare systems, homelessness response systems, public health agencies, and community-based organizations, with not only input of people with lived experience, but as leaders in this work. And all of that connected to our advocacy and the immense need of these systems to share data and space, among other things, to facilitate better coordination of care. We also heard that while policy and funding uncertainties create real challenges ahead, communities across the country are continuing to develop innovative, patient-centered approaches that improve both health and housing stability, while highlighting the need to continue to improve the transitions between these models of care. Today's discussion reinforced that healthcare is not just a response to homelessness, it is an essential part of the solution, whether through integrated care models, stronger care coordination, investments in sustainable financing pathways, or community-based partnerships. We need coordinated efforts to build systems that are more responsive to the needs of people experiencing homelessness. On behalf of Care for the Homeless, thank you to everyone who joined us today and for the work you continue to do in your communities. There's a feedback survey for folks to fill out once they exit the webinar. We would truly appreciate your participation to help us continue improving these public education activities. We will also email the recording and resources shared during today's discussion to all attendees. Thank you again, and we hope you have a wonderful rest of your day. Take care.